Welcome to the Long COVID podcast with me, Jackie Baxter. I am really excited to bring you today's episode. Please do check out the links in the show notes where you can find the podcast website, social media and support group, as well as a link to buy me a coffee if you are able. You should not rely on any medical information contained in this podcast and related materials in making medical, health-related or other decisions. Please do consult a doctor or other health professional. I love to hear from you. If you've got any suggestions or feedback or just want to say hey, then please do get in touch. I really hope you enjoy this episode, so here we go. Hello and welcome to this episode of the Long COVID podcast. I am delighted to be joined today by Dr Mohammad Bashashati, and we are going to talk about all sorts of gastrointestinal problems that people have with both acute COVID and long COVID. So welcome to the podcast. To start with, would you mind just introducing yourself a little bit and what it is that you do?
Thank you for inviting me. I am a clinician scientist, an internist, and a senior GI fellow at Texas Tech University Health Science Center in El Paso, Texas, United States. Since 2003, the focus of my clinical practice and research was on patients with functional GI and motility disorders. My research interests have been the role of the immune system and the pathophysiology of functional gastrointestinal disorders, also called disorders of gut-brain interaction or DGBI. Also the endocannabinoid system as the regulators of GI motility, molecular and cellular mechanisms of gastroparesis, and a surgical approach to gastroparesis. During COVID-19, after seeing the impact of this pandemic on our patients and community, I decided to study COVID-19 and its effects on the GI system. I have published articles and chapters on COVID-19.
Amazing. So I can put links to those articles in the show notes if people are interested in following that up. But that sounds amazing. The GI side of COVID and long COVID is not something that is talked about very much. And yet a lot of people seem to be suffering these symptoms. It's almost like, I don't know, it's a side of it that just doesn't get talked about. So are you able to talk about the GI symptoms of acute COVID, and do we know what proportion of people do experience these GI symptoms?
Sure. Let me give you an introduction about COVID-19 and its respiratory symptoms. Then I will focus on the GI symptoms as well. SARS coronavirus 2, which is the etiology of COVID-19, mainly attacks the upper and lower respiratory tract. An infection with it presents with cough, nasal congestion, runny nose, sore throat, flu-like symptoms, as well as lower respiratory symptoms when affecting the lungs, presenting with trouble breathing, shortness of breath, chest pain, and drop in blood oxygen levels, which in severe cases causes hospitalization, supplemental oxygen requirement, and ICU admission. With vaccination and evolving changes in the virus structure, including the spike protein and a virus genome, we see changes in a distribution of symptoms, mainly shifting to upper respiratory symptoms. Besides all this, COVID-19 may manifest with extrapulmonary symptoms affecting other organs, including the GI tract, which we will discuss more during this podcast. The GI symptoms may affect up to 1/3 of patients with COVID-19 in the acute phase. In our recently published study on about 1,000 cases with positive COVID-19 tests, the prevalence of GI symptoms was significantly higher than other literature. In our cases of both admitted and outpatient COVID-19 cases, 45% had diarrhea in the acute phase, 35% nausea with or without vomiting, and 30% had abdominal pain. I should mention here that all these numbers are based on the earlier variants of COVID-19 from 2020 and early 2021. What happens with the newer variants, including Omicron, yet needs to be explored. So we don't know what will happen with Omicron. Necrosis of the gastrointestinal tract due to clots, decrease in blood flow in a setting of shock, as well as unique histologic features such as damages to the bile ducts, suggestive of direct liver injury from COVID-19, GI bleeding, pancreatitis, and mesenteric panniculitis are some other GI complications of COVID-19. I have to highlight that many of these conditions happen during the acute COVID-19, but some of them may continue chronically.
There are some quite big numbers in there. You mentioned a third, and then 45% as well. That is a big number for something that is not really talked about that much, isn't it?
Yeah, that is right.
So you're talking about the sort of acute phase of COVID, but we know that, again, quite a big number of people with acute COVID do go on to develop long COVID. And do we know sort of how they continue into what we now know as long COVID? And are the people that end up with GI issues as a result of long COVID, are they typically the people that experience them in the acute phase?
Not all long COVID patients had GI symptoms during the acute phase. This is a very interesting question, actually. GI symptoms do not continue in all COVID-19 patients. In some patients, they continue and manifest as long COVID. In our recent study on long COVID patients with GI symptoms fulfilling the criteria for disorders of gut-brain interaction that I will define later in this podcast, 40% developed DGBI during the follow-up, while they did not have any GI symptoms during the acute phase of the disease.
That's interesting. So, the symptoms don't necessarily cross over between the acute and the long COVID. That is interesting, isn't it?
Yes, that is very interesting.
So you've mentioned DGBI. What's that? Post-COVID disorders of the gut-brain interactions. Can you explain a little bit more about what the gut-brain interaction means? Does this tie into where people talk about the gut being the second brain?
Yes, of course. If I want to define the DGBI easily, I have to give you an example. IBS, or irritable bowel syndrome, probably you have heard about it, is the most famous DGBI or functional GI disorder. Sometimes our patients cannot differentiate between IBS and IBD, or inflammatory bowel disease. In IBS, there is no clear gastrointestinal inflammation, and it's a more functional disorder where a function of the gut is impaired, presenting with abdominal pain, diarrhea, and or constipation. We have to note that pain or abdominal pain usually gets better after bowel movement in these patients. Let's now discuss what DGBI are. They are chronic GI disorders without a definite gastrointestinal anatomical abnormality. There are several DGBI, each manifesting with a cluster of symptoms. Some present with difficulty with swallowing, heartburn, esophageal pain, abdominal pain, bloating, nausea, vomiting, diarrhea, constipation, fecal incontinence, pelvic pain, and other symptoms. These disorders are basically due to malfunction of the GI tract, impaired crosstalk between the brain and the GI tract, in association with imbalanced microbiota, immune system, and food antigens. If we grossly examine the GI tract of these patients, we won't see any ulcer, mass, inflammation, or any visible abnormality. In our body, there are two nervous systems. First one is the central nervous system, which is in a brain and a spinal cord. And the second one, as you mentioned, is the peripheral nervous system. A big component of the peripheral nervous system is the enteric nervous system, located in our GI tract wall, consisting of 200 to 600 million neurons. It's a quite high number, large number. Our ENS, or enteric nervous system, is considered our little brain or second brain. When the interaction between these two brains gets interrupted, DGBI happen, or disorders of gut-brain interaction happen. An older name for DGBI is functional GI disorder. The expression functional GI disorders represent functional alterations, including changes in a GI movement, secretion, and visceral sensation, presenting with GI symptoms, including diarrhea, constipation, nausea, vomiting, and abdominal pain, and other symptoms that I explained before. Recently, experts decided to use DGBI instead of functional GI disorders in order to show the importance of the GI tract and its crosstalk with the brain in the pathophysiology of these disorders. Based on definition, patients with post-COVID-19 DGBI should have chronic GI symptoms, fulfilling criteria for DGBI for the last 3 months, with symptom onset at least 6 months before diagnosis. So the symptoms should be chronic. Starting 6 months ago is important. Also, previous COVID-19 infection is important in these cases. Another important point is those who had DGBI before COVID-19, they won't be considered as post-COVID-19 DGBI. So DGBI should happen after COVID-19, that we classify those patients as post-COVID-19 DGBI.
Right, okay. So if people had these conditions before COVID, what about, for example, if there was somebody who had a GI issue before COVID and then developed COVID and it changed or got worse, so they developed a different one? That's a bit of a grey area, isn't it?
Yeah, so if they develop a different one, or if, that is considered post-COVID-19 DGBI. But if their condition gets worse, it is still DGBI, but means COVID, stress, anxiety, and many other things may affect their symptoms. It's already published in the literature. But it is also possible that COVID causes some changes in neurotransmitters, in brain gut signaling, and inducing more effects on these disorders, means causing, getting them severe, or maybe adding some other symptoms to their previous symptoms.
Yeah, of course, because we've heard lots of people say that COVID, almost like it finds out your weak points and then, kind of goes for them. So if you had something in a minor form before COVID, then, the virus is going to seek that out and exacerbate it almost. It's just really annoying, isn't it? It's like it preys on your weaknesses.
That's right, yeah.
But yeah, that's really interesting hearing about all those different symptoms that fit under the post-COVID DGBI umbrella almost. There's a huge number of symptoms there, isn't there?
That is right. We have upper and lower GI symptoms, tons of these symptoms that may make a cluster of symptoms defining DGBI.
Yeah, I think I hadn't quite realized. I mean, I knew, but I hadn't realized, quite how big the GI sort of amount of, the things in your body that are a part of that. There's a lot in your body that is the GI kind of system, isn't it?
That's right. And I have to mention these DGBI have an overlap. Some patients may have functional dyspepsia plus irritable bowel syndrome, or lower plus upper, so they may have overlap. And some of them may start right after COVID-19, while the patient may have some of them before COVID-19. So this is definitely considered a post-COVID-19 condition. Yeah.
Yeah, it's really interesting, isn't it? Right. So do we know what's causing some people to develop these post-COVID DGBIs? What are the sort of mechanisms? Do we know anything about that?
The underlying mechanism of DGBI, including post-COVID-19 DGBI, are not well understood. Besides taking history and performing a physical exam, GI doctors rely on endoscopic, X-ray, imaging, and laboratory tests for a diagnosis of gastrointestinal disorders. As I mentioned before, all these tests will not clearly reveal a specific abnormality in DGBI. Therefore, whatever mechanism proposed in these disorders is microscopical at molecular and cellular levels. Previous experiences with these disorders indicated that an acute event, including an infection, may trigger an increased sensation of the gut, changes in the motility and contractions versus relaxations of the gut muscle, and secretion and absorption of the fluid and electrolytes in a GI tract, which will sustain after the acute event. Let me give you an example on how infection may lead to DGBI. In May 2000, E. coli and another type of bacteria called Campylobacter jejuni contaminated the drinking water supply in Walkerton, Canada. 7 people died and over 2,000 were ill as a result of this contamination. After the acute phase, the incidence of post-infectious IBS 2 years after the outbreak was 36% among those with clinically suspected gastroenteritis. So infection led to post-infection IBS in these patients. Post-infection DGBI was first defined after bacterial infection, mainly gastroenteritis, but viruses may also trigger these conditions. Therefore, we believe that post-COVID-19 DGBI are a form of post-infection DGBI, which happen after COVID-19. Those viruses predominantly affect the GI tract, causing GI symptoms, as SARS coronavirus 2 also affects the GI tract in the acute phase that we discussed earlier in this podcast. It's reasonable to consider post-COVID-19 DGBI a post-infection condition. It is possibly related to the high expression of the ACE2 in the gut. Probably you have heard about ACE2. This is a receptor that is required for SARS coronavirus 2 virus to infect human cells. The infection of the gut epithelial cells triggers an increase in changes in gut secretory function, as well as a low grade of inflammation and changes in gut microbiota. Low grade inflammation can stimulate the enteric nerves and the gut nerves, which always have a crosstalk with our central nervous system. These factors, together with the stress of having COVID-19, anxiety, depression, can generate symptoms of post-COVID-19 DGBI. In fact, these mechanisms have been also described for other post-infection DGBI, such as post-infection IBS.
We'll be right back. I'm interrupting myself for a second to tell you about long COVID breathing. The fabulous Vicky Jones and I have teamed up to bring you long COVID breathing. We are both passionate about sharing our expertise and experience of the breath and how incredibly helpful that can be with long COVID. We've worked together to develop a course that is specifically tailored to those with long COVID. It's a 6-week course with 12 sessions, all delivered online. The community feel and learning that we're all sharing is such a joy. To find out more information and to sign up for our courses, workshops and other shorter sessions, please check out the link below, longcovidbreathing.com, or email longcovidbreathing@gmail.com to start your breathing journey with us. Yeah, that is interesting, isn't it? And this idea of a sort of a stressor, I mean, in this case, we're talking about COVID, but it's almost like, you know, that feeling when you're, you know, if you're nervous and you're feeling a bit stressed and you get butterflies in your stomach, it's almost like sort of that, but amplified, you know, 100 times, isn't it?
Yeah, that butterfly in the stomach may trigger GI symptoms, and that's a stress, and they may lead to some problems in gut-brain interaction and DGBI in the future. So that is possible that the stress works somehow in these patients. But besides the stress, we have to consider that SARS coronavirus 2 also attacks the GI tract and may have local effect as well. It's not 100% stress, but post-inflammation changes in neurotransmitters in the gut, signalings, hormones, receptors may also trigger these symptoms, as well as changes in immune cells, which may continue chronically after COVID-19, may contribute to post-COVID-19 DGBI.
Yeah, for sure. Because, yeah, when you add the virus in on top of everything else, because you've just mentioned the virus being present, you've mentioned inflammation and something else I think you just mentioned that I can't remember. And these are all things that are kind of talked about as being the sort of underlying cause of long COVID. And it's all connected, isn't it?
That is right. Yeah, there is crosstalk between microbiota, immune cells, brain, gut, enteric nervous system. All of these may lead to DGBI, including post-COVID-19 DGBI. The mechanism is not simple.
No, not at all. And it seems to be different for different people as well, maybe.
That is right. So that's why some people, they get it, and some people, after recovering from COVID-19, they don't get DGBI.
Yeah, of course. Yeah, everyone's different, which is both beautiful and frustrating when you're trying to nail down what's causing things, I guess.
Yeah.
We talked earlier about the sort of the numbers of people that were having acute COVID GI issues. What do we know about the incidence of the post-COVID DGBI?
Okay, we have limited studies on this area. A recent study from India and Bangladesh has reported that 9% of 288 adults with COVID-19 infection developed DGBI. IBS happened in 5.3% of these patients. Dyspepsia or upper GI symptoms with gastric upset in 2.1%, and IBS with dyspepsia overlap in 1.8% of the studied subjects at 6 months post-infection. It's important, after 6 months they assess this. We are also expecting another publication from Italy, which will come out soon. Our study published in Neurogastroenterology and Motility was a case series on patients with chronic GI symptoms at least 6 months after COVID-19. Among 164 subjects, 66% developed symptoms suggesting DGBI, 66% after COVID-19. As I mentioned before, 14% of the post-COVID-19 DGBI subjects did not have GI symptoms when they were hit by the virus in the acute phase. Symptoms suggesting functional dyspepsia, presenting with upper abdominal discomfort after eating or with upper abdominal pain were a most common DGBI, followed by IBS-like symptoms in our study. Another study from the United States evaluated 200 patients with history of COVID-19 who were followed up in a respiratory illness clinic during the first surge of COVID-19 pandemic from April to September 2020. From these 200 subjects, without DGBI before COVID-19, 79 developed IBS and or functional dyspepsia-like symptoms. 58 had functional dyspepsia-like symptoms, 2 IBS-like symptoms, and 19 overlap of both functional dyspepsia and IBS. I have to mention that these studies were questionnaire-based. Therefore, to have a more accurate prevalence of post-COVID-19 DGBI, the patients may need further workup to rule out other organic abnormalities.
Yeah, of course. Yeah. And that kind of leads me into my next question, because how do you diagnose them? You mentioned sort of questionnaire-based things, and that, I guess that is useful because you can survey a large number of people by doing questionnaires, but in order to actually sort of examine patients individually, that's going to be a lot more difficult to do, isn't it?
That is right. So the questionnaires are good for screening and for research, that you can cover many subjects in your study. But for the diagnosis of DGBI, we have to rule out organic abnormalities first. Basically, patients with DGBI present with chronic ongoing GI symptoms that necessitate further investigations. Imaging and endoscopies and laboratory tests like blood and stool workup are performed to rule out organic disorders in these patients. There are screening tools such as the ROM4 questionnaire that we use in our study. But to make the final diagnosis, further tests should be performed. For example, for a diagnosis of IBS with diarrhea as the predominant GI symptom, based on patient's age and severity of the symptoms, I may consider doing a stool workup to rule out infection with bacteria and parasites, as well as inflammation. I may do colonoscopy plus or minus upper endoscopy with random colon and duodenal biopsies. If I do not see any gross abnormality, I may do a test to rule out small intestinal bacterial overgrowth or SIBO test, and I may check the thyroid function. So I have to rule out all organic causes of these symptoms before labeling a patient as DGBI in my clinic. So it's totally different than the research.
We'll be right back. Hey there, I'm just jumping in for a second to see if you're enjoying this episode. If you're finding it useful, maybe you would consider sharing it somewhere, a friend, a group, or even on your Twitter feed. If everyone was able to share just once, we'd be able to get this information out to even more people who really, really need it. So please consider sharing somewhere if you possibly can. I hope you enjoy the episode, and thank you so much. Yeah, of course. I've certainly spoken to people, and I've sort of found it myself. You know, you go to the doctors or whatever to get certain tests done, and it is generally, as you said, to rule things out. And the first time I got my bloods tested, for example, I was really pleased when they said, "Oh, your bloods are all normal, everything's fine." And as time went on and my symptoms were still there, and my tests carried on coming back normal, it was almost like I was hoping that something wouldn't come back normal, because then it would give them something to treat. And it's almost, I mean, it sounds sort of similar here. If one of these things did come back with something, then I guess you would be able to treat that because you would know what to do. Whereas if it comes back and you think, well, this must be a post-COVID DGBI, what do you do then? What is the treatment for that, or what would you do?
Treatment is challenging.
Yeah.
It's based on presenting symptoms and the recognized DGBI in a subject that comes to our clinic. Some patients may have multiple DGBI, so you have to use different approaches to treat all these symptoms together. We know about DGBI and functional GI disorders for decades, while the treatment is, as I mentioned, sometimes difficult. The treatment of post-COVID-19 DGBI is not different than the other DGBI. It's not different. For example, I treat IBS patients with predominant diarrhea symptoms with anti-diarrheal medications, antispasmodics to decrease the spasm in the gut, and neuromodulators. Sometimes I may use a short course of an antibiotic, especially in those with small intestinal bacterial overgrowth, or SIBO. If patient comes with heartburn, I may consider acid blockers in these cases, like PPIs. For fecal incontinence, I may give fibers, anti-diarrheal medications, and send patients for pelvic floor training or biofeedback based on the underlying pathology. If I see a patient with rumination syndrome who vomits mainly on digested food in minutes after eating, I consider breathing exercise, medication, mindfulness, and relaxation exercise through using new technologies such as virtual reality. I may use neuromodulators in these patients as well. Therefore, treatment totally depends on a class of DGBI, and patients should consult their doctors for this and get help.
Yes, of course, because everybody's symptoms are different.
That is right.
Yeah, and people can have the same symptoms but in different severities as well, or on different days of the week.
Yeah, so you have to play with the medications, with the doses, and sometimes you may need to take a specific medication, sometimes not. And because of that, we may use PRN, means as needed medications in some conditions. For example, we say if you have this specific symptom on this specific day, take this medication. If not, don't take it next day. So it depends.
Of course, so you can be kind of reactive to the symptoms as they arrive.
Yeah, exactly. You have to tailor the medication and treatment based on daily symptoms.
Yeah, I've described long COVID symptoms as whack-a-mole. So it is a little bit like they keep popping up, and you have to kind of be a little bit reactive, I guess,
Yes.
to when they come up.
Yes.
And you talked about quite a few treatments and stuff there for different people and different symptoms. And you've obviously seen a lot of different people with different symptoms. Do people sort of respond to these treatments, and do they start to recover from the DGBIs?
We still don't know. We don't know what will happen. We need time to see how it goes. But based on our experience with DGBI, I would say these patients may need a long-term therapy course. The good news is the study on post-infectious IBS in Walkerton, Canada, that I mentioned before, showed post-infection IBS cases had a favorable prognosis with a spontaneous remission and recovery in most patients. This may hopefully happen with post-COVID-19 DGBI as well, but we still don't know.
Of course, yeah. But that is positive.
Yeah, that is definitely positive, yes.
So, there are obviously a lot of people that will be listening to this and they'll think, oh yeah, I think I've got some or all of those symptoms. And some people will be able to see a doctor about them, and some people won't for whatever reason, or they may not have a particularly supportive doctor in some people's cases. Is there anything that people can do to sort of self-manage their symptoms sort of in the meantime? And I know that will be a bit vague because obviously we're talking about a lot of different people and a lot of different symptoms.
Yeah, I suggest that they get help from their doctor first. It is very important, because there are some misleading information in the internet, but they have to discuss with their doctor before doing any lifestyle specific change or take any remedies for their condition. If their symptoms sustain, they must try to be seen by gastroenterologists and neurogastroenterologists who are expert in this. There are natural remedies and lifestyle techniques to help with these symptoms. For example, for patients with reflux-like symptoms who come with heartburn, they should avoid food with high acid, or in some of them, they have to avoid caffeine or decrease the amount of caffeine they use. For constipation, they should consider fibers, drinking enough fluid water, and doing exercise. Exercise is recommended for everybody, actually. Yeah. For patients with rumination syndrome, breathing exercise, diaphragmatic relaxation, and meditation would help. For those with bloating or abdominal distension after ruling out conditions like infections of the stomach, which with the bacteria, which is called Helicobacter pylori, after ruling out celiac disease or SIBO, they can consider low FODMAP diet and low salt diet, because salt has been shown to be associated with bloating in these patients. Low FODMAP diet consists of elimination of certain fermentable sugars that may cause intestinal distress, slow reintroduction of them to figure out which one causes the symptoms, And the third step is continuing the diet with those which do not cause the symptoms. So this may also help some patients.
Yes, of course, because you can try cutting things out, but you can't cut everything out, can you? Because you need to eat.
That is right, yeah.
Yeah, no, that's really, really helpful. And hopefully there's something useful there for people that are sort of sitting at home and struggling. But yes, I think definitely people should seek out professional medical help where at all possible.
That is right, yeah, definitely. Because on forums, they recommend specific things to others, take this, take that, take this medication, but they might be harmful. So it's good to discuss with their doctor first before doing them. Yeah.
Yes, yeah, no, absolutely. Because there's an awful lot of people sort of trying their own remedies. Again, it's completely understandable because people are desperate.
It is. They are desperate, but at least discuss with your doctor first. Make sure there is no harm.
Yes, I think, yeah, that's definitely worth saying. Yeah. You talked a little bit about research and, well, needing more research into this area, but what is there going on in the sort of post-COVID DGBI research arena, for want of a better word, at the moment?
Yeah, there are ongoing studies on the mechanisms of post-COVID-19 DGBI, including changes in the gut microbiota and neuronal signaling molecules. In my opinion, the major study would be finding the real prevalence of these disorders, the prognosis, and whether patients would recover by time. This is very important to address. The key point beyond research is to introduce post-COVID-19 DGBI to the medical community. As I heard from some of my patients that they were ignored by their doctors or healthcare providers. For doctors who see patients with DGBI from now on, it is important to have history of COVID-19 in each patient recorded. In other words, from now on, if they diagnose a case with DGBI, they should simply ask, were you infected with COVID-19? And did these symptoms start after COVID-19? That will help the patients. Also, will enrich our databases with those who are affected, providing enough material for the future research.
Yeah, definitely. Because like you were saying earlier, there are people that 6 months on from their COVID infection do start to develop some of these things. So it doesn't necessarily happen straight away.
So we have to recognize this condition, and doctors should know about it, and we should help patients to get better and with providing enough information.
Yeah, definitely. And I guess as time goes on and, cases have been very high recently, there are a lot of people that have been infected with COVID. So it will be interesting to see with time whether the sort of the incidence of this does continue at sort of similar levels.
So some of these post-COVID-19 DGBI studies that I mentioned were from earlier phases of COVID-19. So what will happen with new variants of the virus, we still don't know.
Yeah, it will. It'll be very interesting to see. So thank you so much for chatting to me today. It's been absolutely fascinating to hear all about the GI symptoms. So thank you for that. And thank you for all that you're doing.
Thank you. Thank you for inviting.
Thank you so much to all of my guests and to you for listening. I hope you've enjoyed it, or at least found it useful. The Long COVID podcast is entirely self-produced and self-funded. I'm doing all of this myself. If you're able to, please go to buymeacoffee.com/longcovidpod to help me cover the costs of hosting the podcast. Please look out for the next episode of the Long COVID podcast. It's available on all the usual podcast hosting things. And do get in touch